Morning everybody, welcome to the Integrated Corporate Board of NHS Direct NHS Trust. We have a significant and quite heavy agenda today, which I've sort of pre-warned everybody about. Our biggest and most significant item, amongst a number of significant items, is going to be the update at the end of the consultation period, which Roger is going to lead, and two of our staff representatives are going to speak to that. We also are going to be considering the implications of the Second Francis report, which is really an important topic, and we have a number of procedural things to go through. So I'm going to be setting a relatively brisk pace today, hopefully so that we can spend the time where we really need it and that the important items are not rushed. If anybody feels that they're being bulldozed, please let me know and I will rein back a bit. But I would like to, as well as welcoming everybody in the room, welcome anyone who's watching us online and encourage them to complete a feedback form. As you can probably guess by the packed nature of the room, we have no apologies for absence. It's great to see everybody here. And I also have had no declarations of interest. Are there any declarations now? No? Good. Let's move on then to the minutes of our last meeting, which was on 28th of January. Are there any matters of accuracy on the 28th of January minutes? No, very good. Let's look then at the action log. Nick, would you like to just...
I think it's closed. There are no outstanding actions.
Okay, very good. In that case, we can move straight on to the performance section of the agenda and the Chief Executive's report, which is very brief this week.
It is. Just the point I'd highlight in item 2, otherwise happy to take any questions. In the last week or so, I've been to Chelmsford, Newcastle, Wakefield, Hull and Sheffield. And this week I'm going to Bristol and Stafford, and next week I'm going to Ilford. So what I'm doing is going out and speaking to staff individually in ones and twos, and I'm happy to give any additional feedback on that in the engagement part of the meeting.
Great, that would be very helpful. If we can lodge that there. Are there any other questions to Nick at this stage? Yep. Then Jackie, I think the floor is with you to introduce the performance package, both operational and financial.
Okay, thank you. Again, I'll be able to keep it fairly brief. I think overall performance for January was very good. In particular, taking into account the snow and all the changes that we've got within NHS Direct. In particular, access targets were met for the month in all cases. Particularly good to see abandonment rate and answer in 60 both met, and all of the clinical assessment targets were all met. So I think it's a good month performance-wise. In terms of the financial position, we're still on plan. The year-to-date deficit is reducing, so it's now only 0.8 million. So that's good, and again that is on plan. Identified some risks last month. Those risks are still in place, but pleased to say that we do have plans at the moment to cover all of those risks. So the only thing that they have done is I've changed the forecast outturn to £200,000, which is our original plan, as I just feel that is a more realistic target for us to achieve this year.
Thank you, Jeff. That's great. Well, I think the first thing, so if we take those two things one by one, first of all, the operational performance. I mean, it's tempting when we get these numbers to forget what an enormous challenge it is to carry on delivering an 0845 service safely and effectively whilst going through this incredible transition to a brand new 111 service. So, I mean, that's extremely encouraging to be able to see that we've been able to manage that performance and to recognise all of the work that's going on to continue to deliver that service. Trevor?
At the last meeting, again, performance was good last month as well. We asked that a note go out from the board to all staff recognising that tremendous effort. Has that happened?
I don't think so. So we will rectify that, and I'll send out a note this week.
Excellent.
Okay, that's good. And then on the finance, I mean, last time we spent a few minutes considering the risks because we were at £1 million deficit, which was on plan. But, So, I mean, that is, again, encouraging to see that we're still tracking to plan. Yeah. Does anyone have any questions for Jackie about that? No? Great. Fantastic. Well, I think that brings us to the end of the performance section of the agenda incredibly quickly. Thank you. Now we're into governance and compliance, and the first of our substantial items of the day. Roger, would you like to introduce that? Thank you.
So I've produced for the board this month a similar report to the board, the report I produced for the January board, which is a progress report on the staff consultation that commenced on the 3rd of December. And of course there is a much more detailed report in the private part of the board. So this report just gives you a fairly straightforward update on the activity that's been undertaken during the consultation process. And I have to say, first of all, referring to paragraph 3 of the report, the collective consultation group, which is the formal body in which we discuss matters of importance, has been undertaken on both sides, and particularly on the side of my staff side colleagues, with real constructiveness and real maturity and a genuine understanding of the position we're in. And we've come to a series of agreements in those meetings. But there do remain 2 issues that are outstanding, which the board is already aware of, and they have continued to be topics of discussion in the collective consultation group. And those 2 issues are the evaluation of the call handler position at Band 2, and the process the organisation went through to get there, and the evaluation of the clinical roles, the clinical advisor and nurse advisor roles at Band 5, and also those roles as suitable alternative to employment to our existing Band 6 clinical roles. Management has retained its position on both of these issues, but has agreed with its staff side colleagues that we will go to ACAS, and we have our first meeting with ACAS on the 6th of March. But we felt also that in the public session of the board, it was important that our staff side colleagues were able to state their position on each of these issues, and so we've invited them today to come along and do that. And we've got Sandra Maxwell, who's our senior staff representative from Unison, and she will address the issue relating to the Band 2 call handler position, and Sue Green, who's our senior staff representative from the RCN, and she will address the Band 5 issues. Gary Kerwin, full-time officer for the RCN, has kindly agreed to come along as well. He won't be addressing the board. He's there to support Sue and to some extent Sandra. So, with your permission, Chair, I'll invite Sandra to address the board.
Yeah. Good morning, everybody. Hear me? Yeah.
Dolly, you're very welcome to stand, but there's a chair there if you'd rather sit down. So, however you feel comfortable.
Sit down.
Join us at the table.
Thanks, Roger. Roger's characterised the issues today, and as far as the Band 2 call handler roles concerned, he described the position staff side is that the position should have been evaluated at Band 3. It's not merely frontline staff bemoaning a pay cut. I just want to make that really clear here. Although a move from a Band 3 to a Band 2 is a timetable of 14% pay cut. The move would downgrade the role to the lowest in the whole of the NHS. It reduced the amount of pension the call handler will receive, and it will set back their career progression for those who wish to continue working in the NHS. These staff have already had a 3-year pay freeze, an increase in their pension contribution, and many have lost working tax credits to child tax credits with the changes with the rosters last year. Currently, an agenda for change Band 2 has a starting salary just over £14,000. Many of you will have heard the passionate comments from frontline staff and their managers at the executive briefings that you went to around the country, and of the potential risks to the new service. Staff side can produce evidence that the position of the call handler in NHS Direct 111 is a Band 3 role, as in all the other NHS 111 providers, including the private sector providers, bar 1. The process followed by future NHS Direct in deciding that Job Band 2 call handler failed to follow NHS Staff Council guidance on job evaluation. The Gender for Change job evaluation is binding on local matching and evaluation panels. The handbook clearly states that job evaluation should be carried out by experienced matching or evaluation panel members who will be advised by the appropriate management and staff side representatives from the relevant sphere of work. The outcome will then form the provisional pay band of the post. None of this has happened. The management brief for consideration to the consultation group on the 24th of December candidly revealed that the managers at the time had not been trained nor had any experience in evaluating job descriptions, and that the managers who wrote the job descriptions simply saw a demonstration of pathways, including a webinar walkthrough. At that point, there had been no updating or refresher training for the existing job evaluation practitioners, and therefore inadequate resources in NHS Direct to support the job evaluation process. Because of this, we would contest that there are glaring mistakes in the job evaluation and the subsequent scoring. There has been no explicit advice for those people recruited and appointed to the call handle roles at sites in Milton Keynes, Carlisle and Beckenham that the banding is a provisional banding. Therefore, we contest it's not a binding job evaluation and has consequences for the wider NHS and risks to the new NHS Direct 111. NHS Direct will no longer be able to aspire to be an employer of choice which values its staff and will struggle to recruit and retain staff. One of the Francis Report recommendations was that organisations should support staff to deliver the best care. Providing consistent, reliable care for frail and old people is a priority. It was recognised that services provided to frail older people with complex needs do not have high societal status, and many of the staff providing the care both at home and in hospital, and we could say from our service, at the time of the Francis Report, had few qualifications and low pay, i.e. they were band 2. We can now add to that list future NHS Direct. NHS 111 call handlers are at the coal face of the service. They're dealing with illness and distress day in, day out, speaking to patients and their carers when they're most vulnerable. How do we support those staff and provide a high quality service? Francis concluded that they must have well-designed roles with good support. Our proposal is that the Health Advisor Band 3 job description and person specification are used for the 111 call handler post until NHS Direct 111 service is established. And then, in partnership with staff side and within the JE job evaluation guidance framework, a fully legitimate job evaluation would take place. I'd just like to end with a final word from a member. I'm outraged by the organisation's dismissive, misinformed approach to the banding of the health advisors in the new organisation. As a 111 team manager, I know full well that Pathways involves an increased degree of clinical understanding and critical thinking, hence the inclusion of exams and assessments in the training. And there's an increased responsibility from the perspective of care advice. At the end of last week, we were presented operating procedures for the 111 service were published by the organisation. In paragraph 23.7 it states, where a call handler finishes an assessment during the crossover period in the morning, they will critically think, and they advise the caller to ring, I think it's their GP, so their own GP once it opens again. If they're unsure, they will contact a clinician for advice. This single phrase demonstrates 5 factors that in the job evaluation that would need really praising. Factors on communication, knowledge, freedom to act, plan and mental effort. I have here a list of the pay rates for the other 111 providers as well, and there's other pages that we have presented to the consultation group.
Thank you, Sandra. Would you like to just stay at the table for a moment?
Yeah.
Roger, would you like to open the discussion around this Band 2 evaluation before we move on to the other issue?
Yes, certainly. If anybody wants to
ask questions
or make comments at this point. But what I wouldn't want to do is to begin the process that will be starting with ACAS.
Yeah,
I
so
don't
just
think that would be appropriate.
exactly. So you've told us that you're going to ACAS on the 6th of March,
That's right.
and that the process will continue through them. So
Yeah.
at this point, I mean, I guess what we're asking for is any questions,
points of clarification
or detail, exactly, but not to make any decisions because that's going to be done through the process.
Exactly.
So I've got Trevor and then Steve.
First of all, thanks very much for that. I thought you made some very clear points, and two big issues sort of struck me from what you've said. The first is that all other 111 organisations, bar one, have graded their posts at band 3. So it would be useful to get our understanding whether that's our management side understanding as well. And having got that, is there anything different in our posts which would justify that difference? To me is a key point. The second issue, I think, which was made very strongly, is that we didn't follow proper process, and I think it's useful to get some views on that.
Thank you, Trevor. Let's just hold these questions and accumulate them. Steve.
Well, Trevor's asked one of mine, but the second one is if we go into discussions with ACAS and ACAS agree with staff side, what is our response to that? I mean, is it binding or is this?
No, this is, we go in willingly. We use ACAS as a mediator, and we try to find a position of compromise. But if we found a commission of compromise, then that would be binding. But that would be with our agreement.
Okay.
Nick, did you want to?
Yeah, I just wanted to ask really for clarification from Sandra whether, I mean, I'm not trying to put the issue of band 2 to one side, but are there any other issues which from your perspective on the staff side you think that you should bring to the attention of the board at this point, just as we come to the end of the consultation period? Or is that really the big issue?
Unfortunately, Nick, as soon as the consultation paper was presented and published, the banding of that role jumped out.
Understood that.
And became the issue. And we said to Roger, and this is going to divert focus because it's such an emotive thing. I think now that the structures have been developed and pooling has been published, and I think it's unfortunately reinforced our view and our doubts on the job evaluation process, full stop. Not just for this role. We picked up on this banding straight away because there was you were recruiting into Beckenham, of necessity, to Carlisle and the 111 sites. But there are the job evaluation as a whole.
Right. Okay. Thank you.
Thank you, Peter. And then I'm going to just see if there are any more questions and then we'll just go through them with Sandra. Peter.
Okay. I just wanted to ask about the point that was raised about potentially struggling to recruit staff at this grade. That was a question, or a point that you made quite strongly. And I was a little confused about how it linked to the Francis report, really, because I assume it was to do with the calibre of staff that could be recruited to deal with the issues you raised around Francis. But perhaps that's something, again, that could just be touched on by Roger, if he wouldn't mind, around I suppose we're talking about the calibre of staff who would be recruited at this grade, and the issues around, you mentioned frail elderly and that sort of issue, but and whether that is considered by management to be a problem.
Okay, thank you. So I think I've got.
Can I be reminded of the starting salary for that? She said was
14,153.
So Sandra, there's a couple of issues I think people would welcome your comment on, and then one for Roger. So for you, the thing we'd like to hear a little bit more about is, and maybe from Roger as well. No, actually, it's a Roger issue, isn't it? The other 111 providers. Yeah. So should we go to that first?
Well, I'll address each of the issues, but actually, what I'm going to be doing here is stating the position of management at this point. And the first of those, yes, we know that both with this and with the Band 5 that other organisations have banded differently, but from the evidence we've got, they're banding a slightly different job. And so with ambulance trusts particularly, their job evaluation, in our view, is of a job that isn't the NHS 111 call handler position. Now that clearly is something we'll get into detail with ACAS, but that's certainly our position at the moment, is that the evaluations that have been done in other organisations, certainly in the NHS organisations, are evaluating something different.
Thank you.
So that in relation to non-NHS organisations, I think we would find that the entire package is significantly lower in private organisations, even if the base salary is sometimes higher. And of course, they are not bound by Agenda for Change. They will pay whatever they like in whatever package they want to.
So the second point was, can we hear your response to Sandra's doubts about the job evaluation process?
Yeah, we've used, for all jobs that we've evaluated over these past few weeks, the process that we've used for some years, and we will robustly defend that when it comes to talking those things through with ACAS.
Okay. And then there were Peter's issues about what are the implications for recruitment and what's the link to the Francis report. So Sandra, I wonder if you could tell us a little bit more about why it is you have concerns about possible recruitment issues. Do you have any evidence that you'd like to share with us about that?
But it's more. I mean, it was the first Francis report actually that talked about job design and pupils' morale and how they engage with a job and the support they have around the job. Bearing in mind that the 111s, there's been a loss through COG, through not COG, through GP people coming in. And even prior to this transition, there's been sharing of staff between ambulance trusts and ourselves and backwards and forwards. So people are aware of the roles. And if you knew that you were going to be doing a 111 call handler role within an ambulance trust and be on a band 3, and yet you'd be on a band 2 if you work for NHS Direct 111, and how long would you stay? Because as this document, this operating procedure document that was published last week, they are going to be expected to critically think. They do give home care. All the arguments that have been made to us as to why it's a band 2 and not a band 3, are now starting to fall. As the job is being recognised by the organisation.
And perhaps I'd like to follow up specifically on that critical thinking point. So, as I understood from the extract that you read, you're talking about critical thinking at the point at which GP practices are about to open.
On the cusp, yeah.
So you're saying that we're asking call handlers to remember and think that,
and plan.
So that this is a time when if the person waited 5 more minutes, they'd be able to speak to their own GP practice. That's what you're saying? Okay.
Which is not what Pathways expects them to do. Pathways makes the decision. It's a decision-making software.
Okay. Thank you. Have I covered off everything? Is there anything more, Peter, you want?
I'd be interested in Roger's.
Yeah, there was just,
and maybe Trish's.
Yeah, there was one thing about I mean, our evidence at the moment is that we are not having problems recruiting to band 2. That's the evidence of the recruitment we've done so far. So it doesn't seem to be a market problem. And of course, there is the facility within Agenda for Change to add a recruitment and retention premium if you did have an area where there was a problem. So I mean, I'm not sure if I accept the market related issues at all, but again, that's something we might want to talk to ACAS about. As for the Francis report, I mean, for me, we have evaluated a job at a band. That is the process.
Thanks, Roger. Trevor, did you want to?
I just want to come back to get a little bit of elaboration from Roger. My first question was, is there anything different about our posts? Roger's management response was, the posts are different. It would be useful if you could just give us a couple of examples, perhaps, of the differences that would say our posts aren't as complex as other organisations. I think that would be helpful for me. The second thing was in relation to my second question about have we followed due process? And again, Roger understandably said, yes, we have followed due process. The thing that I was concerned about when Sandra spoke was that the managers who've undertaken job evaluation have not been trained in job evaluation. I took from what Sandra said. Could we have confirmation that our managers have been appropriately trained in the job evaluation process?
So I'll take that one first. I think that we need to make a distinction between managers who are involved in the content of jobs and the managers who actually undertake the evaluation. So you need to make that distinction, and I think that's where kind of I would make the distinction very clearly that the managers who undertake the job evaluation are trained in job evaluation. There may be people who contribute to the content of that job who aren't trained in job evaluation, but they don't need to be. That's the first thing. In terms of are we actually evaluating different jobs? It's my view that what the Ambulance Trust specifically, and they of course are the only trust that we can actually compare ourselves with, they, in the examples that we've looked at, have taken an old job description. In fact, in two cases, old job descriptions of ours, and just evaluated those. And in our view, that's actually not appropriate to the NHS 111 service. So that's the evidence that we have gathered where we have been able to get hold of job descriptions. So it's not actually about the job, it's about a poor evaluation of an old job description. And I think you'd agree with Trish, Trish, from the job descriptions we've seen, they are not evaluating the job we're talking about here, the NHS 111 call handler. So that's certainly our position on
Okay. In that case, Sue, did you have something else?
I did actually. I was just I keep thinking about the implication of the Francis report, and I'm not sure if I understood you correctly, but I thought there was an implication in there that in grading the band 2 as opposed to band 3, that there was potentially putting at risk the sort of frail and elderly people that call us and their carers. And I was particularly interested in following up that because that obviously would cause me concern. I wondered whether we could ask Tricia what your view is as to whether or not this would increase the clinical risk.
Thank you, Sue. I have reviewed the job descriptions, as you would expect, reviewed the Francis report inside and out. My current position is the way in which we recruit staff, the way in which we train staff, the very transparent way in which we continuously audit and assess the skills of our staff, and the openness in which incidents are reported both from our existing staff, from external organisations. I think we have enough robust processes within our organisation for us to identify if the recruitment of a lower grade of staff would introduce risk to the vulnerable, the elderly, and anybody else, frankly, ringing our service. So at this moment in time, I do not have the evidence that having a lower grade of staff introduces clinical risk to our organisation.
Thank you. Okay. In that case, Sandra, I wanted to echo Roger's thanks. Thank you for coming along and for your participation in the process all the way through. Is there anything else you'd like to say before we hand over? Thank you. Okay. In that case, Roger, would you like to introduce Sue?
Yes, so Sue Green is our senior RCN staff side representative in the organisation, and she's going to address the Band 5 job evaluations and also I think challenge our position as Band 5 as a suitable alternative to Band 6 that already exists.
Welcome, Sue.
Good morning. On behalf of the RCN members and staff side, I'd like to thank you all for the invitation today. Before we start, can I just bring your attention to paragraph 4 in the paper submitted to the board this morning by Roger. What it says is that staff side representatives do not disagree with the evaluation of positions with band 5. What I will say is that we absolutely disagree with the evaluation of those positions. The paper submitted to the collective consultation group clearly states this, and I would therefore ask the board to revisit the paper, please. The RCN strongly believe that the Band 5 clinical advisor position is not suitable alternative employment for the current Band 6 senior nurse advisors, nor are we satisfied with the explanation given for the Band 5 scoring of the clinical advisor in the job evaluation, nor are we satisfied that the NHS Direct followed the NHS agenda for change job evaluation process correctly. Very early on in the process, we realised that the implementation of the 111 service was not negotiable. It had the support of the Department of Health and the Secretary of State. As a group, we were aware of the very precarious position that NHS Direct found itself in throughout the commissioning and bidding processes, and how close we were to the service being closed with hundreds of associated job losses. The proposal to compel staff to accept a post that is a band lower, even with pay protection, is in direct contravention of Principle 3 of the NHS Constitution and will affect them in the patient-focused arena that we are all determined to provide. In the NHS Constitutional Section 3A, there is a commitment to maintain and improve opportunities for staff development, specifically a worthwhile job with chances to develop and the opportunity to improve the way they work. The move to appoint staff to a new post 1 band lower is a barrier to this obligation. Through continued service in the NHS, experience and qualifications gained at a continuing education and support environment means that being at the top of a band reflects the personal effort put into developing a career and working to improve the individual service given to patients. Downgrading roles and reducing pay seems to indicate that the organisation is not interested in skills and improvement and does not recognise this as important to patient safety and well-being. We've had no clear explanation to date of the nature of the commissioning contract for the click-to-nurse assessment service. In the absence of such information, we can only assume that this is a rollover from the 0845 service, and NHS Direct should therefore retain Band 6 in this instance, unless they can provide irrefutable evidence that this post requires a significant reduction in critical thinking and freedom to act, and can be undertaken without extensive knowledge and experience. We strongly believe that the Band 5 clinical advisor position is not suitable alternative employment for the current Band 6 senior nurse advisors, nor are we satisfied with the explanation given for the Band 5 job evaluation scoring of the clinical advisor. ACAS gives extensive advice on suitable alternative employment where employees are at risk of redundancy and advise the following 5 points for consideration: status, location, working environment, hours of work and pay. We are disappointed that there seems to be little effort to mitigate the loss of status. We are concerned that the protection of pay and organisational change is time limited, and eventually there will be a significant fall in remuneration for nurses who stay with the organisation. For many senior nurse advisors, joining NHS Direct was a major step in their career. The essential criteria for these posts included a minimum of 4 years post-qualification experience in a variety of disciplines. There were many applicants for few posts, and NHS Direct had the luxury of selecting from the best of those applicants. In the first line manager reconfiguration in 2010, one of the results was that the position of the Band 7 clinical team leader role was reprofiled to a Band 6 senior nurse advisor, clinical lead or a Band 5 team leader post. There are a number of colleagues who took up this offer of suitable alternative employment and are currently on pay protection, some with little under a year left to run. 2009, a Band 5 nurse advisor role was developed and offered as a post to enable staff to join NHS Direct and develop into a Band 6 role. In addition, it was said that this was a new role in NHS Direct which would mirror and reflect the wider NHS family and open up our recruitment pool. It was said that the introduction of the Band 5 nurse advisor role would enable NHS Direct to reflect other career structures within the NHS. In response to the question, will Band 6 nurses be phased out over a set time period, management replied, no, we will always require different levels of nurse advisors and this will offer a career structure within NHS Direct. In essence, Band 5 was stored to the staff side, trade unions and the staff members as a developmental role, despite our reservations. We fail to see how the current senior nurse advisor entitlement action can be similar in status to a clinical advisor. Just looking at the job title, there is an obvious drop in seniority, notwithstanding that the job description is not limited to applicants with a first level nursing qualification. We've also seen homeworking, where the stipulation was that the nurse had to be a Band 6 nurse. We've also had homeworker light, again, had to be a Band 6 nurse to do that. Now, there is a specific issue that surrounds the senior nurse advisors who are currently pay protected. Through organisational change in 2010, these colleagues were moved from the position of clinical team leader as mitigation to redundancy, down to senior nurse advisor. As a result of the current proposals, they will be asked to accept clinical advisor Band 5 roles, a further diminution of their role and status. The current consultation document cites suitable alternative employment as one band up or down. We view this situation with grave concern and the fact that there is only limited policy to mitigate this action. The evidence supports a lack of management clarity between the various roles. This lack of clarity has led to a position where NHS Direct is demonstrating that they have no regard to the career progression of these colleagues. The proposals to force senior nurse advisors into the clinical advisor post as suitable alternatives for employment for some colleagues could impact on their pensions. Trade unions are also not convinced that the appropriate job evaluation procedure was carried out to arrive at the conclusion that the new posts will be a Band 5. If these are new posts, were they done by a desktop method of job matching? If so, what are the arrangements for reviewing these posts and what are the details to ensure that the desktoping was carried out in partnership as per the NHS Job Evaluation Handbook? Can staff side be assured that the same process was applied to the Band 5 post was also applied throughout the organisation and into the new structure? Because it would appear that the job descriptions that have been written in such a way as to fit a Band 5 score, not deliver a post that will deliver a quality clinical service. The job evaluation process and associated guidance is a nationally agreed process between the NHS Staff Council and NHS employers. We do not believe that this process is being followed. We believe that this is to the detriment of NHS Direct and the wider NHS, for the reasons Sandra has already given. Through the negotiation processes, we have clearly shown the differences between the Band 5 Clinical Advisor 111 role and the current Senior Nurse Advisor role. We have shown that despite paying a Band 5 salary, NHS Direct will still get the benefit of nurses working at a Band 6 level and working at this level continually. Nurses cannot unlearn this level of knowledge and expertise. We are committed to reducing the impact of redundancy amongst our members, and we do want NHS Direct to use suitable alternative employment as a way to mitigate against redundancy, but not just to a post at the lowest cost to the employer. Moreover, stated earlier, we do not believe that the clinical advisor post is a Band 5 role, as the lack of evidence in the job evaluation process gives great cause for concern. Finally,
to continue to maintain excellent patient satisfaction ratings, NHS Direct must not dilute its current skill mix to the detriment of patient care.
Thank you very much, Sue. You've raised a number of points there, some of which were similar to the points raised by Sandra, so the job evaluation issues, and a number of which are specific to this. What I'd like to do is just to follow the same sort of process of gather up issues and questions. If people could perhaps try and make clear whether they're looking for further explanation from Sue or whether they'd like a response from management, that would help me a great deal. Peter, would you like to kick off?
Yeah, I just what would be useful from Tricia, I think, would be for me a little bit. I mean, obviously, you're going to talk about the job evaluation process. Maybe again, I don't know if you are, but the issue of career development, which was given a lot of emphasis. I mean, are these roles? Are you able to develop your professionalism, I suppose, is the question that was on the table here. The interesting point raised about whether because your experience is pretty strong, whether you're getting more from these people than you would if they were just coming on stream, I suppose. The point I wrote down, cannot unlearn this level of knowledge and expertise. I mean, that's sort of something which I think happens in lots of places where there's an organisational change, but perhaps we could just get a bit of feedback on that. This question of status, I think, came through a lot to me, whether because it's a lower grade, it's lost status. I mean, to some extent, the evaluation is the key to judging whether it's the right grade, but is there a status issue? Those are the points for me.
Thank you. Any other points? Tim?
Could you add to what Peter just said, the homeworking angle, please, because that's been quite a useful tool for us being flexible as a business, and I think that would be quite important going forward. So perhaps you can add that to your list, Tricia.
Louisa?
And just also to add that is the point about looking through to a nurse and whether there would be any difference in what that nurse did to the new band.
Okay. Thank you. Got that one. Click to call back. Trevor?
It would be useful to get Roger's comment on the very first point that Sue made, and that was about the paragraph 4 in the report, where our report says clearly that staff side representatives do not disagree with the evaluation, and Sue is saying fundamentally you do disagree. So just trying to understand how we've got to that confusion at this stage would be helpful, I think.
Okay. Fine. Well, we've got a list of things which I think are mostly directed to Roger and Tricia. So Tricia, should we start with you? So Peter had some questions about career development, whether we're benefiting from knowledge, from experience, and what about the status of the jobs for nurses? And then Tim had a question about home working. I'm going to hold on the click to call back unless you're able to answer that, in which case please do.
Okay. So first of all, the job descriptions were originally established from a blank sheet of paper. We had the service specification for NHS 111, and we knew that as an organisation we would have to develop our roles appropriate to meet that service specification. So the job description was written knowing the content of NHS pathways, which at that time was likely to be the chosen tool for the delivery of NHS 111. So the job description was written from scratch as what would be required to meet those specifications. And then, as our colleagues have identified, a job evaluation process was then stepped into. Now, for the clinical advisor role in NHS 111, we believe that to be a Band 5 role. It is considerably different in management's belief to the role that is currently undertaken by a nurse advisor in our 0845 service. the rationale behind that is a considerable component of the assessment in NHS 111 is undertaken by the call handler. The role of the nurse in NHS 111 is to assess calls where there is additional complexity, which is steps beyond the role of a call handler. And equally, the vast majority of the calls are validated by a nurse. So that is considerably different, where it is the nurse in the 0845 service that undertakes a comprehensive and thorough assessment in our core service. For career development, NHS Direct, in its introduction of Band 5 nurses, as staff side colleagues also state, was in order for us to bring ourselves in line with the remainder of the NHS, where we could bring nurses with less experience into our organisation in order for us to be able to develop them, introduce them to the professional development and skill set of remote healthcare delivery, and in order for us also to enhance our career structure. Now, I believe in the future organisation there is still an opportunity for career development for those nurses who are coming in as a Band 5. The future organisation does have Band 6 roles, and like many other NHS organisations, you choose which path you wish to follow in order to enhance your career. So that could be a Band 6 role in clinical governance in the future organisation. It could be a Band 6 role as a CQI, which is a quality advisor role. So there are absolutely opportunities for nurses to enhance along the clinical pathway from a Band 5 role right throughout the structure to my position at an executive level. So I believe there are still those opportunities. Status.
I'll pick up the status.
Okay.
The status, Chair, if that's okay.
Yeah.
On the status issue, I think we would accept that there is an argument that if you are expecting an employee to take suitable alternative employment at a band below, that you could argue that there is a loss of status. But ACAS look at 5 things, not just loss of status. They also look at pay, hours, location and environment. And I think in the round, our argument is that, particularly with pay protection and with no change in things like hours, location and environment, that in the round it is suitable alternative employment, even though you could argue that there is a loss of status if you are expecting, we are expecting across the organisation for employees to take suitable alternative employment if it's a band below their current band. So that's our position that we will approach ACAS on in terms of the 5 tests of suitable alternative employment, if you like.
Louisa, do you want to say something about that?
I'll pick up the home workers as well.
Yeah, there is a couple.
Which is related to the Band 5 and Band 6 critical thinking. So it was just to say that at the end of I understand that the interaction that the new position would have would be different to how it is with 0845. But at the end of the day, is there less critical thinking or freedom to act in that pathway, whether it's at the end of 111 when a nurse comes on?
It's very difficult to distinguish between which is the clinical decision making of the nurse and what is the clinical decision making of the software. So pathways is very, it does allow the nurse to have, to use his or her clinical knowledge in order to evaluate whether the recommended output endpoint for the patient is right and appropriate. That is the same in any clinical software you would use. So to say there is absolutely no critical thinking would be wrong. It's used, but the process for pathways is different in that the majority of the assessment is undertaken by the call handler and less is undertaken by the nurse.
But is it that assessment bit that would have the weight on it, or is it the critical thinking bit at the end?
Well, the critical thinking is a small component of the whole package. I don't believe any clinician would not be using any critical thinking.
Okay. So can we move on to homeworking, click to call back, and
Yes.
the question about the we will then ask Roger about the agreement stroke disagreement.
Okay, so as board members will remember, homeworking was introduced 2-3 years ago with closure of one of our sites in the southwest, and at that time we had never thoroughly or robustly tested what was required for homeworking. So as you would expect, as the clinical director and chief nurse, I took the decision at that time that homeworking would only be available for our most experienced nurses until the principles of homeworking had been tested. And I believe that's still to be the case today. However, as in all of these things, we introduce something, we robustly test it, and then we take the learning from that. We do know that homeworking that is proposed for the future still allows nurses to receive and gain support remotely from other senior people. So as the current situation is, homeworking has band 6 nurses. There is an opportunity for us to explore homeworking for band 5, and as I sit here today, I do not believe there is anything of significant concern which would prevent us offering homeworking to band 5 nurses.
Thank you. Can we just then deal with click to call back?
Yeah, okay, so again, click for nurse assessment in our current core service offering has been offered to those patients who use our health and symptom checkers and come in. Because of the way our organisation is currently developed, the majority of those have been assessed and undertaken by our experienced nurses, our band 6 nurses. However, in view of what the future organisation and what our future commissioners require of us, plus the learning that we've taken from those new developments, I equally do believe a band 5 is an appropriate skill set for the future organisation to undertake click for nurse assessment.
Okay, thank you. Roger, can we, I'm conscious of the time,
Yeah,
can we just pick up
yes,
on
very briefly then.
how this disagreement?
Yes, I mean my position on this is that whilst I'm perfectly aware that numbers of colleagues disagreed with the banding at band 5, my understanding was that staff side colleagues' position was that that was not something that they were going to argue about and take to ACAS. They were only interested in the issue of the band 5 as suitable alternative employment to band 6. If the staff side have changed their position, or if I've misunderstood their original position, I don't have a problem with that. I just need to be clear about that when we go to ACAS so that I know what we're arguing about.
Okay, fine. Can I just then thank Sue for coming and speaking to us and for participating in the discussion. Roger, can we just wind up by just by reminding us once again of the process from here? So going to ACAS, what then is the involvement of the board post the ACAS discussions?
Well, the first stage is that we've both agreed that the next step will be to go to ACAS, and that we will, in both sides, I think, in good faith, look for ways in which we can compromise to reach a position that we can both agree with. There is absolutely no guarantee of that, but we're both going in good faith in order to see if we can find some sort of compromise there. If we do, we will inform the board of that. I don't think we need to get the board's agreement of that. We will inform the board of that, and I would probably inform the board outside of the board meeting. I would just let you all know. I mean, that I think is the position we.
So that's what we're hoping for.
Yes.
If on the other hand we're not able to reach agreement, will that be brought back to the board?
Yes.
Yeah.
In the same.
All right.
Same way.
Thank you everyone for participating in that discussion. I think we're clear about how we're going forward. There may be some discussion offline just to be absolutely crystal clear about what the questions are for ACAS around the Band 5 nurse evaluation. But we're hoping very much that there'll be agreement reached, compromise through ACAS, and if not, we'll be back at the table discussing it shortly. Thank you.
Thank you.
Okay. Let's then move on to the gifts and hospitality policy, which hopefully will be a short item. Sarah, do you want to just introduce it very quickly? So my understanding is it's also about conflicts of interest and declaration of those. Yeah?
Yes.
Okay.
The gift and hospitality policy has been reviewed by our executive management board. It's also been reviewed by our audit committee and NHS Council Board colleagues who have introduced and helped us to provide some guidance to staff members on the Bribery Act. And I'm now happy to recommend this policy to the board for formal approval.
Fine. Can we just approve that?
Yeah.
Okay, good. Policy's approved. Let's go straight on then to back to the Chief Executive on the Francis report. So let's just be clear what we're doing here. I mean, we may all as individuals have views about the second Francis report, about issues such as is the answer to failed regulation more regulation, or are 290 recommendations useful or implementable? That's not what we're here to discuss today. We're talking specifically about our responsibility as a board of an NHS trust in the light of Francis to ensure that we are providing safe and effective care. So Nick, on that particular point.
Absolutely. So hopefully my report didn't encourage anyone to stray over into the former territory, which I think is an interesting spectator sport, but not one that is within our purview directly, of course. So I've provided for the board the Secretary of State's letter to you, Joanne, and David Nicholson wrote a sort of an equivalent letter to me, which I'm very happy to circulate as well, but I don't think it added anything very specific. And no doubt the board will want to consider the timing of going out to have such staff listening events in due course. I think to do that right at the second would be extremely problematic, just because of the amount of change that's going on. So we have already discussed the original Francis report when it was produced back in 2010, and just to remind ourselves, I've produced the list of things that the board said that it would do, and it's an interesting exercise to go back and see which ones of those do we think we have really embedded within our way of working, and I think as a board there are clearly some examples where we have. There are other questions where we may be left thinking, have we really followed through sufficiently? And I suggest that we will need to revisit that. We've had the useful step of a board seminar, which of course is not a decision-making group, it's a discussion group, before the second Francis report was opened up, was published, but that was a useful preparatory step. What we suggest is that there will need to be further consideration as to the actions that will rise out of the latest version of the Francis report, and we will come back to the board in due course with those recommendations. So I'm really just inviting the board to say, are you content with what we are doing, what we've got in hand, or do you think that we ought to be doing something different at this moment?
Okay. Can I ask for anybody who wants to dissent from a view that we have this in hand, we look forward to a report coming back to the board on this, to say so now? Okay, thank you. I think we just see this as a progress report, really.
Yeah, absolutely.
And we look forward to engaging on the substance of some recommendations from colleagues.
Can I just ask about the process of delivering this? So will there be more sort of detail delivered over time in these areas? I just asked for something, for example, around, there's a lot of evidence around how people who feel supported in teams deliver much more compassionate care. And of course in here it's aligned. So will there be more around some of these things?
I think what we're looking to do is to come back to the board with, having considered what we decided in 2010, just standing back and reviewing that in the light of the second Francis report and the things that it says, taking into account the discussion at the seminar and any comments made at the board today, with a clear action plan about the things that we think we need to do in addition to that which we've already got in hand. So, you know, what are the arrangements for team working is a question that we will address in that process.
Yeah, I'd like to agree with that, but also maybe underline the fact that the seminar wasn't just a discussion. There was a very clear output from the seminar, which was a series of ideas and suggestions and recommendations that Trish was working on. So it's a combination of that, plus what we've learned from the Francis report Mark II, which wasn't available at that time, plus the things we said we'd do last time that we haven't done.
And also presumably some sense of what you'd want, what might need fixing more urgently than
Yeah. Okay. All right. Thank you very much, everyone. Let's move on to the corporate risk register, which is with Sarah.
Okay, we currently have 7 entries on the public section of the register, and there are no red risks to be reported. The 2 risks relating to Cabinet Office guidelines will be removed from the register this month and managed within the transition and decommissioning work stream.
Okay. Any comments, questions, specific thoughts on the risks in the public risk register at this point? Okay. We are then into our list of minutes, which is very important because of the fact that so much of our substantive work is now done, bless you Nick, in our subcommittees. So we've got, number one, we've got verbal feedback from the 28th of January Future Committee. We're going to have the written minutes in the private section of the board. So Trevor,
that's correct, Chair.
Can I ask you to do that, please?
Yeah, we have a very full agenda. We covered aspects ranging from our contracts, our mobilisation plans, our performance levels across both the pilots and our soft launch sites, our financial results, our risks, and on through our review of patient calls. So a very comprehensive agenda. No one specific issue to draw out, other than the fact that we are at the very heart now of our implementation plans, our mobilisation plans, and our appointment processes.
Okay, thanks. Are there any questions to Trevor? They're more likely to come from the minutes, I think, in the private session. Okay, so we had on paper, we had the minutes from the January Existing Services Transition and Decommissioning Committee, which everybody was therefore able to read. If anyone has any questions for Trevor, I'm sure he'd be happy to take them. I don't know if there's anything you want to underline.
No.
Trevor? No.
Clear from the minutes.
Okay, thank you. No questions? All right. We had in our second dispatch the minutes of the Clinical Governance Committee of the 11th of January. Ditto, I think, any questions to Sue? Anybody has any? No. And then along with those, although in the first dispatch we had the Research and Clinical Audit Report for 2012, I'm sure Sue or colleagues would happily take questions on that. No? And then we had some Audit Committee minutes from the 21st of January. Peter, I think you've already fed back to us verbally. I don't think if there's anything else to say. No.
Nothing wrong last time.
And then we had, I think finally, minutes from the Finance Committee of the 21st of January.
Which we fed back verbally. I've got nothing to add.
Last time. Okay, so nothing additional from you, Tim, on those. Thank you. All right. Are people happy to keep going, or do people want to break? No? Okay, we'll carry on then. We're into the stakeholder section of the agenda. So this is all about patient experience and engagement with staff in the Trust. Let's perhaps start with, following the agenda, feedback from the Existing Services Transition and Decommissioning Committee, who listened in January to some call recordings about hot children and poisons.
Yeah, again, I don't think there are any significant points arising from the recordings we considered last time. There was a general point. I simply mentioned this because it appears on our committee agenda next after this meeting, and that was background noise being heard on the call recordings. Last time we were advised that the background noise that we could hear on the call recordings wouldn't be heard by the patient, but again on the recording we are about to discuss the subcommittee, we have exactly the same occurring, only worse, I think, much more interference from background noise. So I guess that's something we should pick up in the subcommittee next, but it is something which worries me slightly around whether patients are actually hearing some of that.
Perhaps you'd be kind enough to feed that back specifically at our next board, having had your subcommittee discussion. Okay, that's great.
Excuse me.
Sorry, Tim.
Can I just add? There's been on the toxic substances in this report. There's been a particularly tragic case in Derby where a child died, and there was a court case recently. And I think we should just ask Tricia to have a look at that and make sure that we're covered. I only know what I read in the papers about it, and it's been in the press a lot about 10 days or so ago. So I'll give you the references, Tricia, but just to reassure us on the toxic substances stuff.
I know a lot of work has been done on toxic substances audit and re-audit, so I imagine that Tricia, you'll be able to reassure us, but please, just pick that one up. Thank you. Okay, so the Future NHS Direct subcommittee at the end of January listened to some call recordings from the 111 service in the Northwest. Trevor, were you volunteering to feed back on those?
I'll kick off, Chair, and then maybe ask Trish to follow up. Just in terms of process, first of all, what we do now is listen to the calls as individual executives. We offered the opportunity to meet and listen to the calls as executives and non-executives. We have a separate executive discussion, and then we bring it through into the subcommittee. And what we do is actually a critical assessment of our performance in terms of the patient experience of the service, the patient outcomes, but equally in terms of our performance against our operating assumptions, and how we can improve both of those aspects. And there are a number of points of learning that we felt that came out from our call reviews.
Yeah, in particular the points of learning we took from the calls we listened to last month were the repetitive nature of some of the questioning within pathways, also a considerable amount of interim care advice that was shared during that call, and the calls actually arose out of an audit that was being undertaken by our research and audit team as to whether the patient was left with a very clear understanding of where they were being referred to within what timescales. And I believe our evaluation was that the patient was not left clear with the outcome of their next step within the care pathway.
Thank you, Tricia. I think it's fair to say that when the Future subcommittee listened to these calls, in addition to thinking about patient experience, we're thinking really carefully about how these calls are going to work in the new system. Are we approaching them as efficiently as we can? And oftentimes what we're thinking is that increased efficiency will improve the patient experience. So those two things tend to go hand in hand. So that tends to be our focus. And we've got some more to talk about this morning. Okay. So Keisha, we then have trust engagement visits. So Nick's obviously been out and about very extensively. So he'll be able to tell us a bit about the sorts of things he was coming across in talking to staff. Have we had any other engagement visits? Okay, Nick, can we go back to you?
Sure. There's only so much that one learns from reports at second or third hand and written information and data. So for me it was important to go out and be able to talk to staff in, as I say, in one-to-one sort of settings, or 1-to-2 or 1-to-3 occasionally, but mostly one-to-one. So I can actually have a personal conversation with people and understand what's in their minds, how it feels for them, and I can have a proper conversation. And I have to say, overall, considering the huge amount of turmoil and a large amount of stress for some staff, not everybody, but for some staff, how remarkably welcoming everyone has been. So I think perhaps it's just the opportunity to talk is one that's actually welcomed by people. There is a huge amount of uncertainty out there still. I know this. What I'm going to say won't be a surprise to anyone, but it's palpable, and people have a thirst for certainty, whether that's good news or bad news. But they have a thirst for certainty. The uncertainty that's there is much greater for staff in management and support positions than it is for frontline staff, who have a much clearer understanding about their position. And that's understandable. That's how the process has worked. I think the other thing that's very positive is that there's, despite the uncertainty and people waiting for appointments to happen and the like, there's still huge commitment and solidarity that people feel. They feel it to each other, they feel it to their site, and they feel it to the 0845 service that they belong to. And that, again, is very evident. There's absolutely no sense of anyone just kind of throwing their hands in the air and saying, this is all too much, I can't keep working. I met people on their last shift before they transferred to other NHS 111 providers, and they were as focused on that shift as they were on their future. So all of those things very positive. Transfers to other organisations. I mean, in Yorkshire, they're happening. They are very. There are a lot of staff transferring, and even though there's been quite a lot of toing and froing, it's landed in a reasonably good place. I think the issues in the northeast that I saw confirmed that despite our best efforts, that transfer has been pretty much a non-entity, and it just illustrates the difference, really. I'm sure that accelerating, or at least keeping up to pace with the appointments to future NHS Direct is a really key priority for us, so that we can determine people's futures as soon as we possibly can, and I know that's something we'll be discussing, but that very much comes through in the contacts I've had. So a positive exercise, I think, very valuable, worthwhile, and confirming most of the things that I sit and think about when I sit in the industry.
Okay, thank you, Nick. That's really helpful. I'd just like to ask you to think about one thing, which is, I know when you're going out and talking to people, you're particularly interested in hearing about how people are feeling in their personal circumstances and their any transitions that they're doing out of the organisation. But I know from all the conversations I've ever had with our staff that they never lose sight of patient care, quality, and the service that they provide. So I wanted to ask you whether you thought that in having these conversations, particularly with people who may be transferring out, who may feel very open and very able to speak out, whether you might also cover off some of the things that we would want to know in the light of Francis too. So whether you can ask people about any concerns they might have about quality that we ought to know about.
Okay. I mean, I think I covered it broadly by saying that I found a sense of commitment and solidarity, very evident. And that I didn't mean it just to each other as members of staff. I meant to the service that they're providing.
Yeah, that's what I'm looking for. Is just seeing this as an opportunity to get feedback from frontline staff about any concerns they might have. So that's part of the, we're being asked to do staff listening exercises. I think rightly think this isn't the right moment to launch mass listening exercises, given where everybody is. But you have a really good opportunity, I think.
I think perhaps I'm not making myself clear, but as I'm talking to people, I'm asking how is it for them at this moment.
Yeah.
And the sense that I have is that the service that we're providing today is continuing to be delivered in a way that is completely safe and robust, and that people are committed to providing a quality of care. I mean, clearly in the circumstances with such a lot of change, there are opportunities for things to have been to work better, but broadly speaking, I did not go out and get any sense that the current service delivery was in jeopardy.
Okay. Louisa.
I'm sure that anyone who's gone out, in the past has, it would be surprising to see anything else. But I did just wonder, although it clearly isn't appropriate to have some systematic listening exercise, whether we offer any opportunities to get that sort of feedback that in a way you can only get once, in an organisation's lifetime, about what anything that isn't great or that they've seen that should be better. And I just worry that we might miss that when we've got do we have enough opportunities for whistleblowing? In a way, here's an opportunity to be able to ask people about us that would inform our future. Whether relying on us going around and bumping into a few people is really sufficient.
I'm not suggesting that it is, and that wasn't the purpose of me going out, was to do that.
No, it's not.
So I think quite separately, what we talked about under the Francis report heading, we need to look at and bring back proposals for a systematic way of engaging with staff that will ensure that the board is always up to date, given up to date information and feedback.
Yes.
But what I'm gathering as I go around, primarily focused on staff welfare, which is what I'm really out there looking at, is a clear sense that people are continuing to be focused on the service delivery, and I'm not being regaled by lots and lots of stories of people saying, and the last shift I was on, I was just ashamed of the service. There was nothing of that sort at all.
I don't think that anyone's suggesting that. I think it's just a question of when you do have people leaving, whether we have any ability to be able to get any insights from those people leaving.
And I think the other point is that so I think we're not suggesting that we're picking up concerns because people have lost motivation or commitment. So that's not, and we've heard you.
I understand that.
But here's an opportunity for our committed, motivated staff to be very open about anything they feel might be going wrong. And you have a great opportunity to pick that up, I think. Roger?
We're still doing exit interview documentation as part of people's leaving or transfer process. I sent out an email this morning reminding managers of their commitment to do that. It's quite important.
A lot to do, actually.
Yeah, well, I mean, it will give us quite a lot of information, Louisa, actually, which might be useful.
But I hesitated to ask in case.
So we're not doing that just because it's in big numbers.
Yeah, that's what I was going to ask.
Very good, thank you. All right, well then I think we're coming very close to the end of the public section of the board. Is there any other business that anybody would like to raise? No? Then we'll be meeting again in this format on the 25th of March at 10:30. Thank you very much. I'm going to close the public meeting. We're going to have a 2-minute break and then we're going to meet again in private. Thanks a lot.